Thank you so much. And thank you all for attending, depending on where you're coming in from. I know it could be middle of the day, so hopefully you're at least getting to enjoy some lunch as we move through this presentation. And my hope is to talk about a topic that frustrates not only you all, but also about every surgeon under the sun. And that's going to be on some of the soft tissue injuries of the front limb. And so before we get started, here's a list of some disclosures of companies that I've lectured, consulted, or gotten research funding from in the last 5 years. Thanks to Zomedica for sponsoring this webinar, and note that I am a paid lecturer for Zomedica. With that being said, I do believe that this lecture is both scientifically sound and relatively unbiased. So let's take a look at a patient for a second as we watch this dog walk. So, think about if you're presented with this case tomorrow, how you're going to handle things. And let's take it even a step further and say that we would all agree this dog has a left front limb lameness as he's walking. And so you've done your exam, you run all the joints through range of motion, you don't find anything. Perhaps you put the dog on an anti-inflammatory for a few weeks, dog gets better, you stop the anti-inflammatory, the clinical signs come back. And so you say, okay, well, since it hasn't gotten better, maybe we should take some radiographs. And so you take radiographs, and the radiographs are totally normal. And so you say, okay, well, maybe we should try some anti-inflammatories in a period of rest for a few weeks and see how that does. And the dog gets better. And then you allow the dog to go back to normal activity, you stop the anti-inflammatory, and the dog comes up lame again. And so now you kind of sit scratching your head thinking, well, what in the world is going on? What do we need to do for this dog? How do we manage this dog to get the lameness to resolve? And so, when we take a look at radiographs, first things first, when it comes to the front limb, toes and wrist are pretty sensitive structures. And so, obviously, if we have a patient come in with a front limb lameness, we definitely want to make sure that we rule out toe injuries or things between the webbings that could be causing a issue and not get tunnel vision. But most front limb lamenesses in the dog are going to be dictated typically by either the elbow or the shoulder. And so I would highly, highly encourage you to take radiographs of both left and right elbows and shoulders in patients with a front limb lameness for comparison. And so these are the radiographs from that patient that we just saw walking, which when I look at these, and granted, I would encourage you to get orthogonal views, and this is just a lateral view of each, but the shoulder and the elbow are normal. But many times, the one thing I would direct you to be cautious of is when we're dealing with front limb lameness is not to get tunnel vision in focusing on just one joint or the other, because in some situations we can have the so-called shelbow, meaning we have a primary issue in the elbow, and thus, because of the alteration in gait, we now have a secondary issue in the shoulder. But with all joking aside, one of the things I will direct your attention to is to understand that the radiograph that's presented here, this is not a shoulder radiograph or an elbow radiograph. So don't try to skim and getting both objects in the same field of view, because this is a very nice radiograph of the humerus. But we really couldn't make any direct determinations about the elbow or the shoulder based on this view, because the center of the beam is on the humerus. And so when we talk about imaging, imaging the object of interest is quite important. So along with radiographs, how else are we going to decide what might be going on, and or whether we dealing with an issue in the shoulder or the elbow or both? And this is really where the orthopedic examination comes into play and is really a key aspect. But I think you're going to have to really change your thought process when it comes to the orthopedic exam, and start asking yourself, are you getting reduction in range of motion, say on elbow flexion or extension? In a young dog, resistance to elbow flexion should be a big red flag for elbow disease. But then also start thinking about the soft tissues, and are you getting muscle spasm or tightness or palpation on manipulation of the elbow? Is there discomfort on shoulder abduction? Is there pain, spasm, or discomfort on palpation of the supraspinatus or the biceps or the medial shoulder? Can you complete a bicep stretch test? And you might be thinking to yourself, I don't really know what any of these are. And the good news is we'll talk a lot about these things, because I think the orthopedic examination is absolutely critical for these patients. But the one thing to remember is that you're not looking for direct pain or crying out, but we have to change our thought process to slow down the orthopedic exam and really focus on areas of spasm, tension, and subtle discomfort. And so that means when we slow down, we don't want to rush the carpus, the elbow, and the shoulder through range of motion and say, well, I didn't get anything. Because if you do that, you're going to miss these subtle signs. And so you got to really slow things down and start to feel how the tissues are reacting and compare left versus right. And so what I want us to get through in this particular lecture is to first understand uh, what a supraspinatus versus a biceps strain actually is. And then once we recognize that, we're then going to talk about how to diagnose a supraspinatus or a bicep strain, and then what treatment options we have available. The good news is as you'll come to find out in just a moment, the supraspinatus and biceps tend to act kind of in concert with one another in terms of damage, in terms of diagnosis, and also in terms of treatment. So we usually lump those together. And then I'm just going to introduce the concept of medial shoulder syndrome, and then recognize how to diagnose and some treatment options for medial shoulder. But we're not going to go, too deep into medial shoulder. We're going to stay really at the surface there, but we are going to dive into the shoulder tendinopathies in terms of the supraspinatus and the biceps. So what are the types of dogs that we see with a so-called soft tissue injury? Because let's be honest, when you've done a workup and you don't really find anything, and you've taken radiographs and you don't really find anything, you say, well, it must be a soft tissue injury. But where we are as a profession is we should be able to define what soft tissue is injured and what degree is it injured. And so we can see these types of injuries in our weekend warriors. These are our companions. And the unfortunate nature is people are busy during the week, and so the dogs lay around all week. And then they try to make up for it on the weekends. And the tissues just aren't conditioned for that sort of rest and then prolonged activity. And so we can start to see tendinopathies occur there. We can certainly see it in our performance animals. These would be like our dock diving, our agility, our fly ball, disc ball, barn hunt. These animals where they're doing a lot of training, but they're doing a lot of the same repetitive motions over time. And then, of course, our working canines, this would involve our scent detection, our apprehension, and our different types of working canines. And, these dogs do a lot of the same repetitive things over time, but then they also find themselves in all sorts of different environments where they have to navigate different things to set themselves up for potentially a shoulder injury. But the real common theme with a so-called soft tissue injury is that there's multiple failed attempts at resolution, meaning you rest them and they look great, but then they go back to activity and they become lame again. Or you put them on an anti-inflammatory and they look good, and then when you stop the anti-inflammatory, they become lame again. And so our goal should be to say, can we figure out what the injury is and move away from just calling it a soft tissue injury? And I think that allows us to take a more patient-specific approach in terms of addressing the issue. And so just to give you an idea of where we can see these injuries occur, think about flyball, for example. And flyball is just a huge relay race where these dogs jump over these obstacles, they hit a box and grab a tennis ball as a reward. But one of the themes here are these dogs are going at full acceleration and then they are decelerating extremely quickly. And so as you can imagine, when their front limbs hit that box, that causes a sudden stop, which can create injury. And certainly, if not done appropriately, can not only create shoulder issues, but could also create facial and cervical issues, like in this particular scenario. And so training is key, where we teach them to sort of swim off the side and hit it at somewhat of an angle. But the reality is a lot of these injuries, a lot of our supraspinatus and biceps injuries are deceleration injuries. So dogs throwing on the brakes and coming to a quick stop from a rapid acceleration. Versus if we take a look at our working canines, for example, we can see that they put their bodies through all sorts of crazy forces that can set themselves up for different injuries. And so if you're dealing with a lot of performance animals, or you're dealing with a lot of working canines, you have to start thinking outside the box as to injuries, because they can injure all sorts of things that maybe you never even knew existed. So let's talk just a second about the anatomy and function of the supraspinatus. So the supraspinatus is this really big muscle that originates on the supraspinatus fossa, and it goes down, it crosses the shoulder joint, but it's actually outside the joint, and it inserts on the greater tubercle and is responsible for helping with shoulder extension. And it is an active stabilizer of the shoulder during most of the stance phase of the gait. But if we just flip this limb around and look just slightly on the craniomedial aspect, that's where we're going to see our biceps. And our biceps originates on the supraglenoid tubercle inside the joint, and then it emerges outside the joint to insert down on the radial and ulnar tuberosity. So it actually has two insertion points at the elbow, which helps with elbow flexion. And it also helps with some degree of stabilization during the stance phase, because years and years ago, any dog with a front limb lameness that we thought was a soft tissue injury had a biceps tenosynovitis. And so we would inject a steroid in the shoulder, and if they didn't get better, we would cut the biceps and didn't think anything of it. But the reality is we are removing a stabilizer of the shoulder just by cutting it. But also what we'll come to find out is more commonly dogs actually have a supraspinatus tendinopathy rather than just a biceps tendinopathy, which explains why a lot of the dogs that we cut their biceps on then didn't get better. As to why they didn't get better is because we weren't actually addressing the problem. And so we can see that they live very close to each other. They both have somewhat similar functions, but when we think about the term supraspinatus or bicep strain, and I use the term tendinopathy, I don't really use tenosynovitis, but in terms of tendinopathy, that means it's due to chronic repetitive stress over time. And so with these dogs, you might see a unilateral or a bilateral forelimb lameness. If you watch them walk from the side, they'll sometimes be kind of stilted, short-strided in their gait. They tend to actually get worse after exercise. They'll initially be responsive to an anti-inflammatory and exercise restriction, but then over time become less responsive. In the late 80s, it was suspected that Labradors and Rottweilers were predisposed to supraspinatus tendinopathies, but we see them across all breeds. And then with a biceps, we might see a partial response to intra-articular steroids, because remember that the biceps is intra-articular, the supraspinatus is actually extra-articular. But as to why these two particular tendons become commonly injured, we really don't know, because there are other structures in the shoulder. We don't really see infraspinatus tendinopathies. We don't really see deltoid or triceps tendinopathies. I mean, we can, but they're not near as common. And so generally speaking, in a front limb lameness that you've taken radiographs and you've ruled out the elbow and you can't find anything else wrong, it's likely due to a shoulder tendinopathy, when it's likely due to a supraspinatus and bicep strain. And so why do they become damaged? Well, some of the theories that have been proposed would be potentially a lack of blood flow at the origin of the biceps and the insertion of the supraspinatus. And, blood flow is important because it's responsible when there's tissue injury to clean up the damaged tissue, but then get cells for healing to the area of healing. But if there's poor blood flow, that means tissue healing tends to become incomplete, and it usually tends to take longer. And also it tends to, rather than repair itself with nice parallel fiber arrangements, we tend to get haphazardly arranged scar tissue. And parallel fibers of the tendon will help with distensibility and elasticity, but if there's haphazard arrangement of scar tissue, it doesn't distend as well before there starts to be discomfort. And so what we tend to see is injury, partial healing, re-injury, partial healing, re-injury, partial healing, until we end up with scar tissue. And that's why overuse, chronic repetitive overuse, is likely the key to these injuries. And again, they tend to be due to deceleration events of a dog throwing on the brakes over and over and over. And if you think about what dogs love to do in the backyard, they love to run the fence line. So they speed up, they slow down, and they twist and turn. It's that speed up and then slow down to twist and turn where the shoulders are taking a lot of the brunt of the force. Now, the biceps actually tends to become injured more secondarily, because there's only about a 3 to 5 millimeter separation between the supraspinatus and the biceps, such that if the supraspinatus becomes enlarged over time, it can compress onto the biceps, creating a secondary bicipital tendinopathy. And so as we see chronic changes to the tendon, the mechanical properties deteriorate, which means it's not as elastic anymore, and then it doesn't take as much force for it to ultimately fail. And so when we think about the diagnosis of these dogs, we're typically going to examine for symmetry upon palpation. We can actually measure limb girth, and that's a rough correlation to muscle mass, and compare it to the contralateral. We can look at range of motion. If we wanted to become very objective, we can actually measure range of motion, and they might have a decrease in shoulder flexion, but it's not due to because the shoulder joint itself hurts. It's usually due to the restrictions of the soft tissues that's creating the decrease in range of motion. But the biggest thing is we want to palpate the tendons for discomfort as well as pain or spasm, but looking for subtleties, meaning they're panting and they stop panting, or they look around, or they start licking their lips, or maybe my assistant says, hey, this dog's like kind of pushing into me, which means they're trying to get away from me. So they're not going to just outwardly show you signs. You have to pick up these subtleties, and sometimes it means checking one side and checking the other, and then going back and forth until you can convince yourself that you're detecting a difference. And so, just briefly to show you what this is going to look like, this is my own dog, but basically we're going to go into a deep shoulder flexion, and we're going to look for any spasm where the supraspinatus starts to insert. And I'm going to push, and then I'm going to do what's called a bicep stretch test. Notice how I'm keeping the shoulder flexed, and then I'll extend the elbow. And I should be able to get the elbow almost fully extended, and I should be able to hold it without them pulling, without any spasm in the area of the biceps. If I'm not able to get that biceps completed, meaning I try to extend the elbow and they're jerking or pulling, or it's really tight, that can be quite indicative of a biceps tendinopathy. Same thing with shoulder flexion. If I go to deep shoulder flexion and I'm getting discomfort, or when I push there, they're starting to spasm up, that can be a little bit of indicative of a supraspinatus tendinopathy. But even with a supraspinatus tendinopathy, they can have discomfort on a bicep stretch test. So I can't diagnose the difference between a supraspinatus and a bicep strain just on examination alone, but it can increase my suspicion. And also, recognizing a biceps tendinopathy versus a biceps tear is important, because as we'll talk about in a moment, a biceps tendinopathy is treated completely conservatively, whereas a biceps tear is going to be treated more surgically. And so, for example, in this patient, this is going to be a normal bicep stretch. We can get there, we can hold it. He's not jerking or pulling, which would be indicative of a biceps tendinopathy. But in this side, we're able to do a bicep stretch test, but notice how we can just kind of keep going and going and going. And this is going to be because there's a loss of infill, meaning there's a biceps tear. So I can keep pulling and pulling, and there's nothing really pulling back. And usually dogs with a biceps tear, it's not a complete tear. There'll be some fibers hanging on, which tends to result in a lot of discomfort to them. And so once we've done our examination and gotten some degree of an idea of what might be going on, we're likely going to need to look at some other diagnostics. And so we've got things like radiographs that can be utilized. But dealing with a soft tissue injury, radiographs usually aren't going to be that helpful. We might see some mineralization in the area of the supraspinatus or the biceps, which can occur in about 12% of the time. But it's important to remember that these are typically due to chronicity. The calcification itself is likely not causing the issue. We could do an MRI. And I think as we get more and more information on soft tissue injuries, especially in the orthopedic arena, MRIs are going to become more and more and more commonplace. We don't use them as much as we probably should now, because that's going to be the go-to for us on the human side. The problem is it is expensive and requires anesthesia. And then even trying to decide what might be going on, sometimes the radiologist can't even agree. And to point that out, for years and years and years, they would see this hyper intensity on an MRI in the region of the supraspinatus and think that that was actually a supraspinatus tendinopathy, until we had a study that came out in 2018 that found that the supraspinatus normally has a trilinear appearance. And so for years, dogs that we were calling with a supraspinatus tendinopathy on an MRI were actually totally normal. So we need to make sure that we have an individual reading the radiographs that is very in tune with orthopedic imaging, or I'm sorry, MRI. The other thing is we can use musculoskeletal ultrasound, which is actually nice because it's minimally invasive. It can be done wide awake, and it allows us to look at the tissues, but it also allows us to look at the architecture and put a grade on it. And then we can use it for follow-up to determine how things are healing, and the price tag is a bit lower. The problem here is it's very user dependent, because if you get just 10 degrees off axis with an ultrasound probe, you can create a supraspinatus tendinopathy when in fact the tendon is very normal. And so if you have somebody doing them for you, we also need to make sure that they're also very, very experienced. The other aspect is we can use arthroscopy as a diagnostic means. And as technology continues to improve, things get smaller. And so this is the concept of a needle arthroscope, where in a prep room, we can put a small little camera in under sedation and take a look. But we also have to remember that the supraspinatus is extra articular, so we can't see that. Really, what we're trying to do is look at the integrity of the biceps and look at the other structures to make sure there's not something directly intra-articular that we might need to address. But what I would say is I don't just jump to doing diagnostic arthroscopy the first go around. This is usually going to be on those cases that we're following the things we're going to talk about in a moment, and they're just not getting better. And so we need to dive in to try to get this resolved because we're having issues. And so one of the things that's nice about arthroscopy as well, as you can appreciate in this image here, this is more of a biceps tendinopathy where there's some swelling and irritation and synovitis around the biceps, versus a biceps tear where we can actually see that the tendon is torn. And so the patient in the upper left needs conservative management. The patient in the bottom right actually needs surgical management. And so sometimes trying to identify these things is quite important, because I would never want to go in and cut the biceps of the image in the upper left, because that's going to destabilize the shoulder to some degree, and that's not what's needed. But the image in the bottom right, if I try to rehab this dog's just never going to get better, and we're going to spend more of the client's money and waste more time when we could have just gone in and treated it surgically. And so what our current recommendations for treatment tend to be based off of are things like our orthopedic exam findings and some of our other diagnostics, whether it's an ultrasound or a MRI, which sometimes we don't get the ability to do the first time off, which is totally okay, because we can sometimes go off of suspicion of ruling out other things in our orthopedic exam. The biggest thing is we've got to shut them down for a little while. There has to be exercise restriction, but what gets people is the time frame. The exercise restriction needs to be at about the 8 to 12 week mark. And what tends to cause recurrence is people see that their dog looks better, so they let them do too much too soon, and then they come up lame again because they re-injure because they just haven't given the tissues long enough to heal. But if we just let them sit in a crate and do nothing for 12 weeks, then those tissues are going to get really tight. And the minute they go back to normal activity, they're going to become lame again. So the other key ingredient is we have to put them into a formalized rehabilitation program. And then this is also where shockwave therapy is going to really come into play, which we'll talk about how I do it in just a moment. And then in some cases, depending on the severity as well as response to exercise restriction and rehabilitation therapy, we might do intralesional or perilesional injections of a biologic such as PRP. And in the past, we might have used steroids, but I no longer put steroids in the joint because I don't want to create damage and weakening or fraying to the structures of the medial shoulder. And then we also have to make sure we treat other underlying conditions and not miss underlying elbow disease, because if we get tunnel vision and focus just on the shoulder and miss the elbow, then the shoulder issue is going to continuously come up and up and up again until we address the elbow. As far as a surgical standpoint, some of the previous recommendations were to go in and just surgically excise the calcification, but the problem is that didn't necessarily resolve the issue. The mineralization tends to return, and you are removing an active stabilizer of the shoulder, which is probably not ideal. So for me, what is my go-to? Well, if I have a dog with a front limb lameness that I've done my examination and I've taken it at least at a minimum radiographs, and I think to myself, this dog likely has a shoulder tendinopathy, it's likely a supraspinatus or biceps, then what am I going to do? Well, for a supraspinatus, my go-to is going to be Shockwave, and we're going to do 3 treatments separated by 2 weeks. And then once we've shockwaved, we're going to do ultrasound-guided PRP injections around the supraspinatus. Now, obviously, if you don't don't have ultrasound experience or have somebody that can do a musculoskeletal ultrasound for you, then you don't necessarily have to think about doing biologic therapy for supraspinatus treatment. What I would do is ultimately shockwave them every 2 weeks or 3 weeks. We're going to exercise restrict them to avoid the explosive activities, and then we're going to put them into weekly formal rehab programs for about 8 to 12 weeks. In terms of a biceps, it's the conservative aspect is almost identical to a supraspinatus strain, which involves both exercise restriction and formalized rehabilitation therapy. And then we can also do intra-articular treatments of things like hyaluronic acid or biologics such as PRP. Again, I don't throw a lot of steroids in the shoulder joint anymore. If we actually have a true biceps tear, or we have damage to the biceps that we've been trying to get under control and we're just not successful, we could go in arthroscopically and do what's called a biceps release. And so this is a biceps release of the patient that you saw earlier, the arthroscopic video of the biceps tear. Essentially, this is just using arthroscopic scissors to transect the biceps. But before I ever get to transecting a biceps for a tendinopathy, for sure, my go-to is going to be very similar to a supraspinatus tendinopathy, and that is I'm going to shockwave them every 2 weeks for 3 treatments. Excuse me. We're going to put them into a formalized rehabilitation program for about 8 to 12 weeks, along with exercise restriction. And then in these, rather than doing an ultrasound-guided perilesional injection, we'll do an intra-articular injection and just bathe the biceps with PRP after our shockwave treatments. And so we don't need specialized equipment, i.e. we don't need an ultrasound or an ultrasonographer to do this. So for those of you that know how to do intra-articular injections, you can easily, they come in, you shockwave them, you inject the shoulder with PRP, they go to exercise restriction, then they go to rehab about the first week after that first treatment. 2 weeks later, they come in, you shockwave them, you inject them, they're still in rehab. 2 weeks later, they come in, you shockwave them, you inject them, and then they finish out rehab, and then we slowly return back to normal activity. So when we talk about shockwave, we ask ourselves, well, what in the world is shockwave? And it's a bit confusing because it has nothing to do with an electrical shock to the patient. It's really the deliverance of a high intensity sound wave that's created by changes in pressure. So the best example here would be thinking about the lightning thunder scenario. So lightning is the electrical impulse, and then thunder is that sound wave that follows. And in some situations, it might be so severe, it like shakes the windows and walls of your house, but it also shakes the windows and walls of your neighbor's house. And so it's a sound wave, but it's not focused. And so with shockwave, the goal is to create a focused sound wave to be directed to the tissues in response for a healing aspect of things. And so the way we characterize this is going to be, we have this sound wave that's generated outside of the body that's characterized by this low tensile amplitude, but you can see how quickly it gets to how quickly it gets to peak pressure and stays there a very short period of time, and then it drops off. But then we have this slight negative dip, which is actually important because in vitro it's been shown to induce these cavitation bubbles to increase tissue permeability, to upregulate anti-inflammatory mediators as well as growth factors, and also the release of free radicals. So in other words, we're helping with tissue healing. But if we look at all the mechanisms of shockwave therapy, once we have the release of that mechanical energy to the target tissues, we see things like the expression of increased cytokines and growth factors, the decrease of inflammatory mediators, the promotion of neovascularization, which is great for tendinopathies where there's already a low or poor blood supply, improving cellular proliferation. So in a lot of these cases where they're chronic and stagnant, not doing a lot, we can upregulate cells for tissue healing, upregulate resident stem cells, as well as provide analgesia through increasing serotonin activity. And so if we look at sort of the three-pronged aspect, we have that primary effect, which is the generation of the mechanical forces homeostasis, which is doing those things that we just talked about to the tissues in terms of increasing growth factors and cytokines, decreasing inflammatory mediators, promoting neovascularization, increasing cellular proliferation, and providing analgesia. But then we also see that secondary effect, which is that slight negative dip with those cavitation bubbles, where we get the release of additional growth factors, anti-inflammatory mediators, and free radicals. But then for tendons, from a mechanical standpoint, we also get mechanotransduction, because when that sound wave is delivered, that creates compression and tension along those tissues. And we know that tendinocytes, when they're healing, need some stimulus to help with biological responses. And so this compression tension or mechanotransduction can help with tissue healing. And so if we look at on a sort of animal model study, we know that shockwave therapy was thought to improve tendon and ligament healing via neovascularization and release of growth factors. And so in rat models of Achilles tendinopathies, they did find increased release of various growth factors for tendon healing. And then in a rabbit model of a patellar tendinopathy, they not only found an upregulation in tendinocyte numbers, but also found an increase in tensile strength. So not only were there healing cells there, but those cells were actually creating a stronger tendon, which in theory would hopefully minimize tissue injury. But if we look at in the literature what we have in our patients in terms of clinically relevant studies, we have this one study which is a retrospective study. They took 15 dogs with a shoulder lameness, and they just suspected that they had a supraspinatus or biceps or medial shoulder disease. They didn't really work them up fully, and they found that if they just rested them, they did nothing more, they just rested them, virtually all of them failed that, which is a no-brainer. And so in this case, what they did is they just simply added in shockwave therapy. They did 3 treatments separated by 3 to 4 weeks apart. And what they found long-term wise was that about 64% had an improvement. So simply just adding shockwave therapy and doing nothing more, we see a 64% improvement, which isn't bad, but I think we can probably add in some things to get that up, which is why I love this next study, which was also a retrospective study, but they actually had dogs with confirmed supraspinatus and biceps tendinopathy via musculoskeletal ultrasound. They treated these dogs with 3 treatments separated by 3 weeks apart, and they added in a rehabilitation program. So the things I said that we need to do as a minimum: exercise restriction, formal rehabilitation therapy, and shockwave therapy, what we see is an 85% success rate. So we bumped that 64% up all the way up to 85%, which for a chronic change to a tendon, to me, 85% improvement is actually quite good. But look at the average recovery time. It was right at about 4 months. So when we talk about the exercise restriction standpoint and the fact that it's going to take a long time, these owners have got to be patient. And that's the killer for dogs having repeat injuries, is we don't rest them and treat them long enough. And that is going to be a big takeaway for you from this. And so we have other things that we need to be doing from a rehabilitation standpoint. In the early phases, it's going to be a lot of manual therapies to release some of those trigger points, improve comfort, and we can add in modalities such as laser therapy or therapeutic ultrasound, underwater treadmill therapy. But I think the reality is, for me, if I was going to do a single modality based management strategy, that's where shockwave therapy is going to win on that one. And then we're also going to work on balancing and early strengthening. So we're not, changing the length of the tendon. These are isometric exercises, and also working on body sense awareness. And then later on, where we're actually lengthening and shortening the tendon and muscle units for end-stage strengthening. And so if we sort of look at what we can put together as prognosis in these patients, from our one study, we found that if they do just shockwave alone and rest, 64% improvement. If we do rest, shockwave therapy, and rehab, we see 85%. And I bring this to your attention because there's been a couple of studies that have looked at the addition of things like stem cells and PRP. And this one study found that dogs with a grade 1 or 2, that really with exercise restriction and rehab, only 42% responded to that. And so then I would think, well, if you had just not done that and added in just Shockwave, you probably would have had a better outcome. Or if you had done that and added in Shockwave, you would have had a better outcome. But then what they found is that if they added in both stem cell and PRP, they saw an 82% return to function. And so then I look at that and think to myself, well, stem cell therapy is upwards of $4,000. And so if you do that with rehab therapy and you get an 82%, we can save the clients $4,000 and do Shockwave plus rehab and have a better outcome. So, we have to put into perspective of priorities as far as what we're going to do to manage these, which is why I think Shockwave therapy can be very helpful, with the other key being rehab therapy and exercise restriction. So just to bring in this aspect of medial shoulder syndrome, this tends to be an open diagnosis of a unilateral forelimb lameness that tends to get worse after exercise. They may initially be responsive to NSAIDs and exercise restriction and then become less responsive over time. They may not have any lameness at all. And we started seeing this more commonly in our agility dogs and our performance dogs, where they would have a shortened stride length or knocking bars or basically having performance related issues. But if you look at those first three bullets, what does that make you think of? Well, it should make you think of a supraspinatus or a biceps tendinopathy. And so, that's why these structures, when they're damaged, have very similar presenting signs. I can't watch a dog walk and say that dog has this going on. That dog has a supraspinatus tendinopathy, but the biceps and the medial shoulder are totally normal. I can't do that just on an exam. I can start to fine tune it a little bit on an examination. But if we look at those structures that make up the medial shoulder, we have our medial glenohumeral ligament, which is a passive stabilizer. And this is the one we've always put all of our effort and focus into thinking about damage. But we also have our joint capsule, but more importantly, we have our subscapularis, which is sort of this fan-shaped structure that originates on the subscapular fossa, and it inserts on the minor tubercle. So it kind of comes into insert just between the biceps and the medial glenohumeral ligament to help adduct and extend the shoulder, as well as aiding and maintaining flexion. So as I bring this up, we take a look. This is going to be normal shoulder, okay? So as we're coming up, we're going to start to see the MGL there, and then coming in oblique behind that is going to be the subscapularis tendon. So that's a normal subscapularis tendon. There's our biceps right there to the right, our joint capsule in the back. So biceps here, subscapularis tendon to the left, and then coming into view there, that's our medial glenohumeral ligament. So that's what normal should look like. Because I bring this up because you're thinking to yourself, well, I've never even heard of this condition. So does that mean it never happens? And, you ask yourself, is this a common or a rare problem? Well, it tends to be diagnosed rarely, but it actually probably occurs more commonly. And so it's been said that the MGL, so the medial glenohumeral ligament, plays a role in shoulder stability, and such that 70% of dogs with chronic forelimb lameness have pathology to the MGL. And the MGL pathology is the most common form of shoulder instability. And this was defined by a French surgeon, Dr. Bardot, in the late 90s. And I would make sense that dogs with a chronic forelimb lameness would have some pathology to the MGL, likely because it's secondary due to chronic compensatory changes. But one of the things that I think we've been missing is the subscapularis. We've been putting so much focus on the MGL as being the course of what's damaged. We really have ignored the subscapularis. And I personally think that dogs with subscapularis pathology are more lame and much more harder to address. And so when we look at the reasoning for this, one of the things that's interesting when it comes to the MGL is the clinical significance to damage. And at the end of the day, not to bore you with a bunch of literature, but we really don't know. This study actually transected the cranial arm of the MGL in normal dogs and found that it had nothing to do with shoulder instability. It caused some inflammation. And so then they speculated, which we all know is how great that is in a study, that maybe with repetitive motion, it would result in shoulder instability over time. And so, what that brings up is the question of what structures have to be damaged to cause a clinical issue. And we see this more and more diagnosed in agility dogs, which makes sense because there's a lot of rotary motion chronically and repetitively over time. But what do dogs, our normal companions, do in the backyard? They speed up, they slow down, and they twist and turn. So they do a lot of twisting and turning, which means they're doing a lot of chronic repetitive twisting on their shoulder. So why this issue really makes it challenging is this is a dog that has no MGL whatsoever. You should not be able to see the subscapularis back there, which is right there. So the medial glenohumeral ligament is totally gone, but this dog is completely sound and has no issues. Versus this dog who also has a medial glenohumeral ligament tear. So the medial glenohumeral ligament is torn. It's still there, but it's torn from its attachment. And the subscapularis is pretty normal, but this dog is severely lame. So here we have very similar arthroscopic findings, but two very different presentations, which is what makes it very challenging. Because these dogs may have no lameness all the way up to a severe lameness. And where we tend to think about examination-wise is going to be with shoulder extension and abduction of the shoulder. But what you don't want to do is just extend the shoulder and then pull the leg away, because all you're doing is pulling the scapula off of the body wall. Because in the past, we thought about maybe they have an increase in abduction angle, but I don't rely on abduction angles, as we'll talk about in just a moment, because to me, they don't really play any role. But ultimately, what I rely on is discomfort. And so how are we palpating these dogs? So what you're going to see is I'm going to find the acromion. I'm going to take my fingers, I'm going to push that against the body wall. I'm going to extend the shoulder to about 45 degrees. I'm going to keep pressure on the acromial process, and I'm simply just going to try to abduct. In other words, I'm trying to, at the shoulder joint, abduct the shoulder, not pull the scapula off of the body wall. So let's take a look at that. Extension, acromion process, we push, and then we see if we get any abduction there. So if we take a look at that sort of in a head-on view, this is what this is going to look like. Acromion process, we push, and then we're simply trying to abduct. So basically, I'm holding the scapula onto the body wall and just abducting the humerus. And I'm not necessarily looking for an increase in abduction angle. I'm looking for pain. And that's because we now have a number of studies that question angles. This is one study that found that there was very poor repeatability and accuracy at detecting angles in normal versus abnormal dogs. But it's been shown that in normal sled racing dogs, they can have abduction angles all the way up to 70 degrees and be totally fine. The other thing that makes this challenging is that diagnostics are quite tricky. You know, we can take radiographs, but again, it's a soft tissue issue. An MRI, this would be some that are the go-to. For me, this is my go-to if I have a suspected medial shoulder case that's just not improving the way that I would expect it to. Some will do a musculoskeletal ultrasound. However, the problem is you can't get the probe exactly perpendicular to the structure, so they're off axis, which I think can create some false changes that are going on that might not really be there. And then, of course, we have arthroscopy. And in the past, it's always said that arthroscopy was the gold standard, but now there was a recent study that came out that found that we can only see about 23% of the subscapularis. So even if we look at it and it looks normal, that doesn't mean that proximal to there's not pathology that we just can't see. And that's why I think an MRI is probably needed in these patients, because we can see changes such as some mild fraying to the medial glenohumeral ligament versus where we actually have just complete tearing of the medial glenohumeral ligament. So we can classify them as mild, moderate, or severe, but the problem is when it comes to just the medial glenohumeral ligament, that might not be playing that much of a role, but the subscapularis is probably playing more of a role, and the problem is we can't even see a quarter of it with a scope. In terms of treatment, it's also quite controversial and debatable. You know, do we treat these surgically? Do we treat these conservatively? And if we're going to treat them surgically, what do we do? Do we take a radiofrequency probe and heat up the tissues to cause it to shrink but then become brittle? Do we go in and reconstruct these structures? Do we transpose the biceps? Do we imbricate the subscapularis? And there was a study that showed that surgical reconstruction does have a higher likelihood of success compared to non-surgical management, but that's likely on the cases that are in the extreme, the ones that have not gotten better or that have severe damage. And so for me, my approach to dogs with medial shoulder syndrome is going to be, I'm going to put them in hobble, so a device that they can't do this, for about 4 to 6 weeks, and then we're going to have exercise restriction, we're going to have formal rehab therapy, we're going to do Shockwave, and then after my Shockwave, I'm going to do an intra-articular injection of PRP. My Shockwave and my PRP are both going to be every 2 weeks for 3 injections. And so I treat it very, very similar to a supraspinatus or a biceps tendinopathy. The difference is I put them in hobbles to minimize strain on those structures. And so with shockwave therapy, again, we're going to do 3 treatments every 2 weeks, somewhere in the neighborhood of 750 to 1,000 pulses at the E6 setting. So that's about 0.5 millijoules per millimeter squared. And so with these cases, I don't necessarily just MRI every one of them. What I do is if I have a sneaky suspicion of a supraspinatus or a biceps tendinopathy, then I'm going to exercise restrict them, rehab them, shockwave plus or minus PRP. If I have discomfort with shoulder abduction, it's going to get the same thing, but they're also going to get hobbles. It's not until they stop or they either don't respond or stop responding to this management strategy where I might say, we might need to do a little bit more. We might need to do a diagnostic arthroscopy. We might need to do an MRI. And then in these cases, at 4 weeks, I get them out of the hobbles and we start some strengthening exercises. I don't want to leave them in hobbles for too long. And so just to kind of show you how tricky medial shoulder syndrome is, this is a paper that myself and PJ, he's another surgeon from Canada. This is us doing a arthroscopic MGL reconstruction. And another surgeon, we actually did a survey study looking at these things, which was just accepted recently to the Canadian Veterinary Journal. But the takeaway here is between sports medicine specialists and surgeons, there's a lack of evidence on diagnostics and recommendations and treatment options and rehab plans and overall outcome. However, most would agree it's due to chronic repetitive strain. And the nice thing too is that the currently available diagnostics are of questionable accuracy. So again, relying on shoulder abduction angles, but thinking more about pain, is that when we think we have a case of medial shoulder syndrome, we don't jump straight to surgery. We're going to rely more heavily on rehabilitation therapy and only perform surgery in unresponsive cases, which tends to be ligament reconstruction or subscapularis imbrication. But the problem is that can be sometimes a pretty complex surgery. So what I want us to do is eliminate this term of just soft tissue injury. If you have an adult dog with a front limb lameness that's either become non-responsive to NSAIDs or exercise restriction, or you take radiographs and the elbow is totally clean radiographically, and again, we never rule out the elbow, but it's clean radiographically, then we would consider a supraspinatus, a biceps, or a medial shoulder syndrome. If we have no pain on shoulder abduction, then it's likely a supraspinatus or biceps. If we have pain with shoulder abduction, then it might be a supraspinatus, biceps, or medial shoulder. And so my go-to for these conditions are going to be shockwave therapy plus or minus PRP. And then the other thing is a formalized rehabilitation plan with exercise restriction. And so we see the lack of typical inflammatory responses, which is why NSAIDs typically aren't completely effective. And then also what we need horribly are more controlled objective studies. I mean, we really only have a few studies here or there. We don't have a lot of controlled objective studies as to what we should be doing with a lot of these patients. And so what I'll do is I'll stop sharing my screen in just a moment and I can happily take some questions. I think we've got about 10 minutes for questions. If a question comes up, here's my email address. Feel free to email me questions.